Two trials that could change antibiotic stewardship, DOTS and PETERPEN. What if we could treat complicated Staphylococcus aureus bacteremia without keeping a central line for 6 weeks? And what if some bloodstream infections caused by ESBL-producing organisms could be treated without a carbapenem? Two important trials, the DOTS trial and the ongoing PETERPEN trial, are challenging how we think about both questions. But the results require careful interpretation. The problem with prolonged IV therapy. Complicated Staphylococcus aureus bacteremia typically requires 4 to 6 weeks of intravenous antibiotic therapy. That frequently means a PICC line, outpatient infusion services, laboratory monitoring, home nursing, and the risk of catheter-associated thrombosis, occlusion, or infection. Dalbavancin is a long-acting lipoglycopeptide with a half-life of approximately 14 days. The DOTS investigators asked whether dalbavancin could allow selected patients to complete treatment without weeks of conventional intravenous access. DOTS trial design. The Phase 2b DOTS trial randomized 200 adults with complicated Staphylococcus aureus bacteremia. Importantly, these were not patients with uncontrolled bacteremia. Before randomization, patients had already received initial effective therapy and had documented clearance of their blood cultures. Participants were then assigned to either standard intravenous therapy for 4 to 6 weeks or dalbavancin administered as 2 1,500 mg infusions given 1 week apart. DOTS results. Here is the headline. Dalbavancin was not superior to standard intravenous therapy. The probability of achieving a more desirable outcome with dalbavancin was 47.7%, which did not meet the trial's pre-specified superiority threshold. But not superior does not mean ineffective. Treatment failure and adverse outcome rates were similar between the two groups. Therefore, the practical interpretation is that dalbavancin may be a reasonable completion strategy for carefully selected patients after bacteremia has cleared and the infection is clinically controlled. Who may benefit from dalbavancin? This strategy may be particularly valuable when maintaining conventional intravenous therapy is difficult. For example, a patient who cannot safely manage a PICC line, a patient with limited access to outpatient infusion services, a patient at high risk for catheter complications, or someone whose social circumstances make 4 to 6 weeks of daily intravenous therapy unrealistic. But dalbavancin is not a substitute for adequate source control. It should not be used to ignore persistent bacteremia, an uncontrolled abscess, an infected prosthetic device, or inadequately treated endocarditis. The key phrase is completion therapy after initial stabilization and blood culture clearance. The ESBL controversy. Serious and slightly dramatic. Now let's discuss PETERPEN. For years, the Merino trial has shaped the treatment of bloodstream infections caused by ceftriaxone-resistant Escherichia coli and Klebsiella pneumoniae. Merino found higher 30-day mortality with piperacillin-tazobactam compared with meropenem. After that study, many clinicians moved toward carbapenem-first treatment for ESBL bloodstream infections. But Merino had important limitations. The trial was stopped early. It enrolled fewer patients than originally planned. And piperacillin-tazobactam was not administered using an extended infusion strategy. Why extended infusion matters? For beta-lactam antibiotics, efficacy depends heavily on the amount of time the unbound drug concentration remains above the organism's minimum inhibitory concentration. That is called time above the MIC. Extending the infusion can improve pharmacokinetic and pharmacodynamic target attainment, particularly when the organism's MIC is near the susceptibility breakpoint. PETERPEN was designed to revisit the Merino question using extended infusion dosing for both piperacillin-tazobactam and meropenem. PETERPEN interim results. According to an interim analysis presented at ESC-MID Global 2026, extended infusion piperacillin-tazobactam was non-inferior to extended infusion meropenem for treatment failure at day 7. That is potentially very important. It suggests that, in appropriately selected patients, optimized piperacillin-tazobactam dosing may eventually provide a carbapenem-sparing option for some ESBL bloodstream infections. But we need to be careful. This was an interim analysis. Enrollment is ongoing, and the final mortality and treatment failure data are still necessary before this should produce a broad change in clinical practice. Should we start using piperacillin-tazobactam? So, should we now treat every ESBL bacteremia with piperacillin-tazobactam? Absolutely not. Until the final PETERPEN results are available, carbapenems remain the most reliable therapy for severe ESBL bloodstream infections, particularly in patients with septic shock, high bacterial burden, uncertain source control, or organisms with borderline susceptibility. Even if PETERPEN is ultimately positive, patient selection will matter. The organism must be confirmed susceptible using reliable testing, the dose must be optimized, the infusion must be extended, and the patient must be clinically appropriate for a carbapenem-sparing strategy. The stewardship message. The DOTS and PETERPEN trials address two different stewardship problems. DOTS asks whether selected patients with cleared complicated Staphylococcus aureus bacteremia can avoid weeks of catheter-dependent treatment by completing therapy with 2 doses of Dalbavancin. PETERPEN asks whether optimized, extended infusion piperacillin-tazobactam can spare carbapenem exposure in selected ESBL bloodstream infections. Both approaches could reduce treatment burden, both could decrease complications and costs, and both could improve antimicrobial stewardship, but neither trial supports indiscriminate use. Final takeaway. Here is the clinical takeaway. Dalbavancin may be a reasonable completion option after Staphylococcus aureus bacteremia has cleared and adequate source control has been achieved. Piperacillin-tazobactam may eventually regain a role in selected ESBL bloodstream infections, but the PETERPEN results remain interim and the final data are essential. Good stewardship is not simply using fewer broad-spectrum antibiotics. It is choosing the narrowest effective treatment at the correct dose for the correct patient at the correct stage of the infection. And sometimes, one study does not close the debate, it reopens it.